Welcome back to Diabetic Foot Files. I am so grateful again to Dr. Hardiman for his episode yesterday. I'm so grateful to him. He's one of the most amazing doctors I've ever met. So thank you again. Big shout out to him. So welcome back to Diabetic Foot Files, where toes tell the truth, compression reveals compliance, and wounds don't lie. Wounds really don't lie, okay? Sometimes they lie by covering up and they'll like do a false skin cover up, but they really don't lie. So today we're going to talk about one of the oldest compression therapies that are still being used today. And I've noticed that some people just use it as a one size fit all for venous stasis ulcers, and it's really not a one size fit all. Okay. Yes, it's kind of like baseline, but a lot of people have seen it. Is this beige paste soaked wrap, okay, that people wrap the venous leg ulcers in, right? And I've seen patients even come into my office, remember a lot when I was in the States, they'd be weeping, the girls would be weeping, 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 and they'll have the Unna boot, and I get it, the zinc, right? But I don't think people understand how wounds work. Wounds are very particular, and wounds are not a one size fit all type wound. I've never met a wound that's a one size fit all. That's why wound care is a specialty. That's why there isn't a one size fit all medicine to heal any type of wound, right? Because there's different things that causes a wound, and that's why some people don't get a wound, right? So there's different things, but people have to understand the chemistry behind it. Because thank God for, like I said, people might hear me over and over again just thanking my mentors, but I've seen now because I couldn't imagine having mentors that didn't have the passion that gave me my passion because they were very intelligent. They knew what they were doing. They studied all the time and they were like, pioneering in science. And I thank God and all my mentors yet again for teaching me so much. And nothing's wrong with not knowing anything. And the whole point of not knowing is to learn, right? But let me get out of that. But I've noticed that some people overuse it and some people misuse it. Okay. So today we're going to break down exactly how it works, what it actually is, when to use it, when it actually works, when not to use it, why so many people still use it, and how it even came about in the first place. So, what is a Unaboo? I always love saying Unaboo, but a Unaboo was developed in the late 1800s, forgive me, by Paul Gerson Unna. He was a German dermatologist, and he was treating venous, chronic venous leg ulcers. And if anybody's been with chronic venous leg ulcers, they know they have a high recurrence. On top of that, they take a very long time to heal, especially if they're not with the right treatment or the right compression. And remember, it's also a vascular problem. Sometimes people need to get that vein pretty much closed off, right? So, like a venous ablation, there's different things now, okay? But at that time, there was no modern compression stockings, there was no multi-layer wraps, no advanced wound dressing, no negative pressure therapy, and he developed the Una, which was a paste bandage containing zinc oxide, glycerin. Okay, so everybody should know what glycerin is. It's like a gel-like thing. Gelatin, gel-like water, okay? And the idea was simple. It provided a semi-rigid compression and soothing zinc paste to treat the venous stasis ulcers. And for its time, it was revolutionary. Bravo, yay. So, what is it made of? Like I said, the classic Una boot, the gauze bandage is impregnated with zinc oxide paste applied from foot to below the knee, okay? Covered with either a cohesive, like we use Coban, right? Or elastic wrap, right? And often finished off with Coban or similar outer dressing. Some people like Rebril to use in between it, right? But zinc oxide is the biggest key on it. So why do they use zinc oxide? Zinc oxide or zinc plays a huge role in collagen synthesis, epithelialization, anti-inflammatory modulation, and it has mild, let me say it again, mild antimicrobial properties, okay? Mild. Remember, there's a grading system. There's mild, there's moderate, and severe, okay? So zinc alone does not heal the ulcer, okay? Compression is what helps heal the venous stasis ulcer because you're stopping the venous reflux and you're pushing the fluid back up, right? But like I said, it's zinc oxide, gelatin, glycerin, and water, okay? And a gauze substrate. So, zinc oxide is an inorganic compound. It's mildly antiseptic. It does have some astringent properties and anti-inflammatory properties. So, the molecular role of zinc in wound healing. Zinc is a cofactor for over 300 enzymes, including DNA polymerase, RNA polymerase, matrix metalloproteinase, MMPs, and superoxide dismutase, okay, which is an antioxidant enzyme. And in wound healing, zinc contributes to the fibroblast proliferation, the collagen synthesis, the keratinocyte migration, and immune modulation. However, zinc in a Unna boot is topical and largely superficial. It does not penetrate deeply into ischemic tissue. Okay? It mostly benefits a skin barrier support, irritation reduction, and mild antimicrobial surface effects. Okay? It does not reverse the venous hypertension. So the structural chemistry of gelatin. Gelatin is derived from hydrolyzed collagen. So chemically, it forms hydrogen bonds when cooled. It creates a semi-rigid matrix when it dries. And this is critical because you apply it when wet, right? The bandage is flexible when it's wet and it dries because the gelatin cross-links, the water evaporates, and the matrix stiffens. And this creates an inelastic compression system. That stiffening process is mechanical, not biological, okay? Now, the glycerin. The glycerin is a humectant, okay? Like it humidifies, it tracks water. It's hygroscopic, meaning it attracts water. And forgive me if I pronounce that wrong. It softens the tissue. So its purpose, the glycerin in the unicle, its purpose is to prevent the wrap from becoming brittle. It maintains the flexibility. It reduces skin cracking. It keeps the paste from drying too aggressively. Okay. Now, the physics of compression and how it actually works. Okay. The real therapeutic mechanism of the Uniboot is not the zinc, it's the pressure. Okay. And the pressure obeys the laws of physics. So, if anybody who's taking physics, we all take it if we're in medicine, Laplace law, okay? The critical concept of Laplace law. Or maybe I'm saying it wrong, but Laplace law. Let me just spell it. Laplace. I just call it Laplace law. So compression pressure is governed by Laplace law. Okay. Forgive me if I'm pronouncing it wrong. But the equation is pressure equals open bracket, tension time layer, close bracket, divided by open bracket, limb circumference times bandage width, close bracket. Okay. So in like a fraction. Okay. Meaning that the smaller the limb circumference, the higher the pressure. The more tension there is, that means the higher the pressure. The more layers there are, that means the higher the pressure. This is why the ankle gets more compression than the calf. Okay. And that's exactly why we want in in venous disease. So venous hypertension, the problem that we're actually treating. So venous ulcers occur because the venous valves fail, the blood pools distally, so down to the toe, like down to the toes, right? The hydrostatic pressure increases, the capillary leakage occurs, the fibrin cuffs form, and oxygen diffusion decreases. And in the result of that is a chronic inflammatory state and tissue breakdown. And what does compression do? Compression reduces the vein diameter, increases the venous flow velocity, decreases the reflux, reduces the edema and improves microcirculation, and the zinc soothes and the pressure heals. So, inelastic versus elastic compression. So, a Una boot is an inelastic compression system. Okay. This means low resting pressure, high working pressure. Okay. So working pressure occurs when a patient walks, when the calf contracts, when the muscle expands against a rigid wrap. Okay. And that resistance increases venous returns dramatically. Resting pressure is when the patient is lying down, there's minimum pressure, and there's a less risk of ischemia if properly applied. Sometimes you can literally strangulate, okay? So I remember in a rotation, they taught me how to do the folds for the Unabu so that it doesn't strangulate the patient's leg. But this is to make the Unabu ideal for ambulatory patient. So why can it fail in a non-ambulatory patient? So no calf compression means no working pressure. And in a bed-bound patient, the venous return benefit drops significantly because the compression becomes pretty much static in the bed-bound patient. So how does a multi-layer compression work? Modern multi-layer compression, I remember Coban 2. I remember Coban had those nice systems that come in the box and you got the 3 layers. Like I said, chef's kiss, I miss that. A really great Wound Clinic has it all. Okay, so a multi-layer compression works by having a padding layer, a short stretch layer bandage, and a long stretch elastic layer, and then a cohesive outer wrap. Okay, so let's break down the biomechanics of that. Okay, so elastic compression, the long stretch. Elastic bandages, the stretch is going to be like over 100%, right? And it provides a sustained resting pressure. Maintain compression even when the patient is not moving. So the pros of that is continuous pressure. The cons of that, yeah, can be dangerous in arterial disease, okay? And the higher resting pressure can cause discomfort because some patients do not like the multi-layer compression. They say it's painful, it's too tight, and you should be very, very cautious when if the patient has any type of arterial disease, okay? You don't want to strangulate their leg. Now, short stretch compression. Short stretch bandages, they stretch less than like about 70%, provides a lower resting pressure, higher working pressure during ambulation, and safer borderline for arterial. We'll see, because I'm very precautious when it comes to arterial disease. And then a multi-layer system combines controlled gradient pressure. So like it'll be like 40 mmHgs at the ankle, and then it'll be 20 mmHgs below the knee. And so there'll be better edema reduction, better pressure distribution, and greater sustained compression over a few days. And this is the engineer system, okay? So the Una boot is a semi-rigid paste base, but the multi-layer compression is a calibrated mechanical engineered like system. So when it comes to pressures and numbers, therapeutic compression for venous ulcers along the ankle, they usually say 30 to 40 mmHgs. Mild compression is usually like what you can get over the counter is 15 to 20 mmHgs. High compression is 40 to 50, and that's in special cases. And in my opinion, I believe vascular should be the only one applying applying that or prescribing that because you want to make sure that you're not strangulating the patient's limb, okay? So, like I said, Una boot pressure varies significantly based on the application technique. Remember, I talked about the folds because some people don't put folds on the Una boot. The, I like doing the folds because it does make sure that it doesn't strangulate, right? The limb length, the bandage tension, and the number of layers that you use. Okay, so the variability is quite limited, but a multi-system layer is more reproducible, in my opinion. So, can a multi-layer compression outperform an Una boot? So, a multi-layer system maintains the pressure longer, can handle the exudate better, can offer more consistent gradient, and are adjustable. Una boot it dries out, it loses conformity as the edema reduces, it loosens, and are less customizable. But Una boots are affordable, simple, and accessible, okay? Which is why they remain widely used, okay? Now, critical clinical point. Compression without ABI assessment is dangerous. And I think everybody knows how much Gabby takes vascular seriously. Yes, vascular, 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 right? So if the ABI is less than zero point 0.5, you are at risk of ischemic necrosis. If the ABI is from zero point 0.5 to zero point 0.8, modify compression only, very little. I honestly, you have to get vascular clearance before this. And if the ABI is greater than like zero point 0.9, a standard compression is appropriate, but pressure applied to ischemic tissue will cause tissue death. Okay. Compression must follow a vascular evaluation. Okay. So keep that in mind because if you can't feel their pulses, and they didn't get vascular and you're gonna apply compression for no good reason, and then all of a sudden their toes turn black. Yeah, please, the whole thing is to do no harm, okay? So, mm, next. So when will a Una boot not work, okay? Like I said, arterial disease. So if the patient has a low ABI. So if the patient has an ABI of less than zero point 0.5, that means they are most likely have critical limb ischemia, right? And they would have something called rest pain and possibly necrotic toes. Compression, what can compression do if the patient has low ABI and arterial disease, right? What would compression do? It would further reduce the perfusion. It can cause tissue necrosis. It can worsen the ischemia. So, compression plus ischemia means disaster, okay? So, you must check the patient's vascular status before anything. Now, next, when a Unabu will not work. In infected wounds with heavy drainage. For some reason, people think that's why Unabu should be applied, but it's not, okay? Una boots are not highly absorptive. I think anybody who's seen a Una boot can tell that it's not. It's literally gauze. It's like perforated. Like it has nice little squares in between, right? It can trap moisture. So if you have a heavily draining ulcer, putting a Uma boot on it that has glycerin and water and the wound is already draining, right? Why would you put more moisture onto the wound, right? And then it can macerate the surrounding tissue as well. So if there is something like purulence, osteomyelitis, heavy exudate, you may worsen the wound and you may worsen the infection by sealing it in with the Una boot. So if it is an infected wound and is heavily draining, yes, the Una boot might not be the best choice. Okay? Like we said, it can seal in the infection. If you notice purulence, if you notice that it's heavily draining, you do not want to make the surrounding tissue macerated. You do not want to trap the moisture in, okay? Next, if the patient is non-ambulatory, okay? Una boot depends on like the function of it. Mostly depends on the calf muscle pump function. So if the patient is bedbound or wheelchair bound or has severe muscle weakness, the working pressure of the Una boot mechanism doesn't activate. There's no calf contraction. So if there's no calf contraction because the patient's not ambulatory, that means there is minimal venous return enhancement. Next, neuropathic diabetic ulcers without a venous component. If the ulcer is plantar ulcer, if it's pressure related or is it neuropathic, compression alone doesn't do anything for the patient. So do not put a Ona boot on a neuropathic diabetic foot ulcer. Okay? You need offloading for a neuropathic diabetic foot ulcer, especially if it's on a pressure related zone. Okay? A Una boot is not a substitute for a total contact cast. So, like I said, why do people still use it? I'm not against Una boot. I love me a Una boot. Okay? I just know when to use it. Okay? If the wound is getting worse, if the wound is heavily draining a lot, there are other theories. Like I said, a multi-layer compression, but you have to get vascular clearance first, right? And like I said, the reason why I kept people keep on using it is inexpensive. I was looking in the supply, medical supply, it's like less than $10, which is really good. It is easy to apply, but it has to be applied correctly. Okay. I do think that people should put folds in it. Okay. And it's very familiar in wound care clinics. People love it. Okay. And it's heavily ingrained in the training culture of wound care. Okay. But modern compression systems are now multi-layer wraps. They have adjustable Velcro compressions, okay? And so what does the evidence say? Compression therapy is pretty much gold standard for venous ulcers. Healing rates significantly improve with sustained compression. However, healing depends on correct diagnosis. That plays a huge role as well. I had a patient today and referred them to a doctor, and I asked if the doctor gave a diagnosis, and they said no. I said, "Pardon, I?" They said, "No, the doctor didn't give a diagnosis, and they just glanced at the leg wound." So I was like, "Okay." Nothing I could do, nothing I could say, because you know, that's the way things roll over there, so but I just told them, like, make sure that the doctor gives them a diagnosis so they know what they're actually treating for the patient, okay? And make sure the patient get adequate arterial supply because that patient toes were turning gangrenous, unfortunately, and they were trying to add compression to it for whatever reason. And make sure the patient is compliant, make sure there is glycemic control, and make sure there's edema management. And I'm kind of just not upset, but I just want people to just take the time to properly evaluate the patient and not glance at the patient, especially when they're using their hard-earned money to pay out of pocket because the patient didn't have insurance, and you're just glancing at the patient and didn't even do a full evaluation on the patient. And I'm kind of confused, I'm kind of confused of why some people do what they do, and they're in the medical field for whatever reason. Yeah, but like I said, Uniboot is good. It works very well, but you have to use it on the right type of wound, okay? Some clinicians use Uniboot by default, and I've noticed that a lot of people do that, but that tells me when people use the Uniboot by default, just say Uniboot, 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 I've always told multiple people there is such a huge variety and plethora of wound care products for wounds, okay? For a venous ulcer, yes, Onabu might be the best thing. There are also mixed leg ulcers as well, okay? Onabu might help with that. If the vascular status is unclear, I'm not sure if owner boot would be the best thing because that's a little bit of what we call lazy medicine because compression must be individualized. Okay. It's not automatic. You have to individualize every patient. That's why I tell people, like, just like what Dr. Hardiman said, get to know your patient, understand what's going on with their life. Okay. And like I said, Una boots are ideal for venous stasis ulcers once the venous stasis ulcer is confirmed. Make sure that ABI is adequate enough to handle a Una boot and that you're not causing more ischemia. Make sure the patient is ambulatory, okay? Make sure it's moderate edema. Make sure it's not a heavily draining ulcer, okay? Make sure there's no active infection, okay? Make sure before you put it, is this the right patient? Is it working beautifully? Is the wound getting bigger? Is this with the wrong patient? Is it causing more harm than good? These are the questions you need to ask. So the Uniboot works great. I even use Unaboo for soft cast. I love me an Unaboo, okay? I love me an Unaboo, but it's not a universal one size fit all type of thing for leg wounds, okay? Like I said, Paul Gerson Una, he named it after himself, which is great, okay? In the 1800s to treat venous disease, and it worked. It worked by compression, not by magic, not because of the zinc alone. It worked by compression, okay? But compression without vascular assessment is quite reckless. So use it wisely because the toes tell the truth. So, like putting an Una boot on a patient whose toes are getting gangrenous, you tell me, okay? You tell me. You tell me. Okay, if they're dusky and they're beginning to show signs of wet gangrene, but they also have leg wounds. Why would you put Unna boot, tight Unna boot on their legs? But mm, swelling reveals the diagnosis. Hopefully, we will get to a consensus where we try to do less harm and more good and evaluate the patients appropriately. But like I said, Gabby loves me a Una boot, and I hope this episode was very helpful because I've been noticing a lot of people use Una boots misuse, overusing it, okay? And then the wounds are turning green, they're draining, they're getting bigger and wider, and they don't understand why. And they're just like, oh, you're supposed to use the Unibut. I'm like, but why is the wound getting bigger after you've been using it for maybe a month or two and it's still getting bigger? It's infected now. And for some reason, they just think that's the only option. And it's not. There are other things like hydrophobia blue. Works very well on leg ulcers. We like it a multi-compression layer. Make sure you get vascular assessment. But I hope this was helpful for everybody with the Unibuild because, yeah, it works very well when assessed and applied to the right wound. And hopefully this was helpful. This is Diabetic with Files with Dr. G, and take care of your feet and legs because they take care of you and toes tell the truth.